Hi guys, in this video we're gonna talk about the definition, classification, etiology, route of transmission, pathogenesis, symptoms, diagnosis, treatment and prevention of the urinary tract infections. So let's begin. Infection in any part of the urinary tract are known as UTIs or urinary tract infections. These are associated with bacteriuria, that is the presence of bacteria in the urine, or in pyuria, that's the presence of WBCs in the urine. For UTI, the bacteriuria must be more than exponent 5 organisms per ml of a fresh midstream urine sample, and so this is the threshold of organisms that can cause UTIs. These UTIs are classified according to anatomy and clinically. Anatomically, they are classified into upper UTI and lower UTI. Upper UTI includes the infection of kidney, that is pyelonephritis, and the infection of the ureter. And lower UTI includes the infection of bladder, urethra, and the prostate, that are cystitis, urethritis, and prostatitis respectively. Clinically, they are classified into uncomplicated UTI and complicated UTI. Now here is a comparison between uncomplicated and the complicated UTI. If the patient has UTI, if the UTI occurs in a healthy patient, it is usually uncomplicated UTI, and if it occurs in immunocompromised, it is complicated UTI. A patient with structurally and functionally normal urinary tract uncomplicated UTI and structurally and functionally abnormal urinary tract, such as in horseshoe kidney, pelvic or male rotated kidney, that are structurally abnormal urinary tract, and where there is an obstruction, it can lead to complicated UTI, or functionally abnormal as an atonic or neurogenic bladder. Uncomplicated UTI is mostly associated with the premenopausal adult women, and complicated UTI is associated with the male gender. So in females, uncomplicated UTI is common, and in males, there is complicated UTI. Uncomplicated UTI occurs in adults, whereas complicated occurs in childhood. And for pregnancy, the uncomplicated UTI occurs in a non-pregnant women, and complicated occurs in a pregnant woman. So an adult, non-pregnant, premenopausal women have uncomplicated UTI, and male gender, childhood, or a pregnant woman have a complicated UTI. And if the patient has no comorbids, it is usually uncomplicated UTI. But if the patient has comorbids such as diabetic mellitus, hypertension, or chronic disease, it is uncomplicated UTI. Other than that, the uncomplicated UTI is also associated with secondary factors such as indwelling catheter, hospital acquired, or if the bacteria have increased virulence or antimicrobial resistance. The roots, the etiology, now the most common cause of UTI is E. coli. Other than E. coli, there are Proteus mirabilis and Klebsiella, which are associated with uncomplicated UTI. And for complicated UTI, along with E. coli, there are Pseudomonas and Enterococci. These organisms can cause complicated UTI. The catheter-associated UTI is mostly caused by yeast and Staph epidermidis. And for urethritis, it is mostly associated with the sexually transmitted organisms such as Chlamydia trachomatis, Neisseria gonorrhoeae, and ureaplasma. Now, the routes through which they enter the urinary tract, the most common route is the ascending, in which the organism enters through urethra and ascends upward. Other than that, the hematogenous route, which is not very common, but the second most common we can say, other than ascending, it occurs in patients with Staph aureus bacteremia. The other routes are lymphogenous, which is very rare and seen in severe bowel infection or retroperitoneal abscess. The other routes are iatrogenic or extension from the neighboring organs. Now the pathogenesis, how they cause the infections. The first step is the contamination, that is the bacteria contaminate the periurethral area, and after the contamination they enter the urethra, and through the urethra they go into the bladder, and there they colonize. So the colonization in the urethra and the bladder occurs, which triggers an inflammatory response, and this inflammation of the bladder is called cystitis, and inflammation of the urethra is called urethritis. And after that, there is a neutrophil infiltration, and so we can see in the bladder there are neutrophils and the bacteria, and these bacteria now multiply and evade the immune system due to their virulence, and then they form a biofilm. That is, they stick together and adhere to the surface so that they can survive for a longer time. And if they survive, they ascend through the ureter into the kidney, and here again they colonize, and colonization triggers inflammatory response, and now the inflammation in the kidney is called pyelonephritis. So here cystitis, urethritis and pyelonephritis occurs through these steps, and now this bacteria in the kidney, they can go through the renal vein into the systemic circulation and cause the bacteremia, which leads to severe complications such as septic shock. And if this inflammation in the kidney, this inflammatory cascade continues, it can lead to interstitial nephritis, which ultimately ends in the acute kidney injury. So this was the ascending route of infection, the pathogenesis through the ascending route of infection. The bacteria enters through the urethra, ends in the kidney, causing the acute kidney injury. The hematogenous route of infection is very simple. The bacteria is already present in the blood. That is, bacteremia is there, and then from here they go into the kidney. They colonize, and again this the steps from here: colonization, and then inflammatory response, the pyelonephritis, the interstitial nephritis, and then this. So this was the pathogenesis. The symptoms are different for lower UTI and the upper UTI. The lower UTI includes urethritis, which has the characteristic symptom of urethral discharge. Other than that, there is dysuria, urgency and frequency, that is difficulty in urination. The urgency is that patient cannot control urination, and frequency is the repeated urination. But there is no fever in urethritis, and there is burning with urination. For cystitis, there's also dysuria, urgency and frequency, and there's no fever. But one thing is that there is no urethral discharge. In urethritis there is a urethral discharge, but in cystitis there is no urethral discharge. And another characteristic of the symptom of the cystitis is this suprapubic pain and the pelvic pressure due to the inflammation of the bladder, and there is hematuria present in cystitis. For prostatitis, the symptoms are different for acute and chronic. For acute prostatitis, there is fever and perineal pain, but for chronic, there is no fever, and there is dysuria, urgency and frequency, as in cystitis and urethritis. So these are the similar to them, but the characteristic symptom is the symptoms of obstruction, such as hesitancy or dribbling, poor steam. The upper UTI is mostly pyelonephritis, and there is a clinical symptom, the classical triad of fever, pain and vomiting. The fever is usually high-grade fever with chills, and the pain is loin pain or a flank pain over the kidneys. And along with vomiting, there can also be nausea and diarrhea. The classical triad of fever, pain and vomiting occurs in pyelonephritis. Now for diagnosis, the presumptive diagnosis is done by the urine analysis through the dipstick test, and for confirmation we go for the urine culture, and for complicated cases we go for urinary tract imaging. And other diagnosis, tests include the blood test, CBC and FPR, beta HCG levels, etc. to exclude the ectopic. The first test, that is urine analysis. Now dipstick test, this tells us about four things, that is pyuria, bacteriuria, hematuria or the proteinuria. That is whether the WBCs are there, bacteria in the urine, blood in the urine or not, protein in the urine. Now this for pyuria, the marker for the pyuria is increased leukocyte esterase, and for bacteriuria the marker is an increased nitrites. In the normal urine there are nitrates are present, but if bacteriuria occurs, the bacteria in the urine converts nitrates into nitrites, so we find increased nitrites. The urine culture is a gold standard test, and the culture is usually taken from the fresh midstream urine sample. And this tells us about the number of organisms. If there are more than exponent 5 organisms per ml of a fresh midstream urine, which I told you is the threshold for diagnosing UTI, if there are more than exponent 5 organisms, the UTI is confirmed, and it may be symptomatic or asymptomatic. But if there are less than exponent 5 organisms, we call it as a negative culture or a sterile pyuria, and we can see this sterile pyuria in some conditions, most commonly in the renal tuberculosis. And other than that, if the UTI is treated for less than 2 weeks prior, we can see sterile pyuria, or if there is UTI is inadequately treated, or in calculi or certain condition, the diseases like prostatitis, Barrett tumor, or polycystic kidney disease. The urinary tract imaging is done in complicated, in high-risk patients or complicated UTI. The options are ultrasonography, CT scan or MRI, IV urography, and widening cystourethropy, retrograde urethropy, or cystoscopy. These all are the options, but mostly ultrasound, CT scan, and IV urography, these are mostly done. The indications for the urinary tract imaging are children or men with UTI, women with recurrent UTI, patients having more than 2 episodes of pyelonephritis, or if the nephrolithiasis is suspected, or a patient is having the gross hematuria. So these all cases suggest the complications, and in these cases urinary tract imagings are indicated. Now the treatment is mostly done through antibiotics, and it is different for the lower UTI and upper UTI. The lower UTI can be uncomplicated or complicated, and the treatment, the antibiotics are different. The drug of choice for the uncomplicated is the this combination of trimethoprim and sulfamethoxazole, and for complicated, the drug of choice is fluoroquinolones, that are ciprofloxacin and the coamoxiclav. The second line agents for uncomplicated are amoxicillin, nitrofurantoin, cephalexin, and ciprofloxacin. These are the second line agents, and this combination is the first line or the drug of choice for the uncomplicated. And for urethritis, since it is caused by the sexually transmitted organisms, so we give drug according to the organism. For Neisseria, it is ceftriaxone, and for chlamydia, we give doxycycline or azithromycin. And for prostatitis, we give this ciprofloxacin and with this combination. So ciprofloxacin and trimethoprim sulfamethoxazole are, this is the treatment for the prostatitis. The upper UTI can be severe or mild. Mostly it is complicated, but it can present as a mild or a severe case. If it is mild case, the oral antibiotics are given, and if it is severe, first we will give the IV and then switch to oral if the patient is clinically improved or afebrile. For the mild case, the drug of choice is this ciprofloxacin. Since it is a complicated but a mild case, so oral ciprofloxacin is a drug of choice for upper UTI. But if it's severe, we have options like cefuroxime, ceftriaxone, gentamicin, or coamoxiclav. This coamoxiclav is a combination of ampicillin and sulbactam. So these are the options for severe upper UTI. But for pregnancy, we have different we have exceptions, because in pregnancy the drug of choices are cephalexin, amoxicillin, and nitrofurantoin, and there are contraindicated drugs. The contraindicated drugs are this combination of trimethoprim sulfamethoxazole, fluoroquinolone, and tetracycline. Remember, these two were the drug of choices for uncomplicated and complicated upper or lower UTI. So they were the drug of choices otherwise, but in pregnancy they are contraindicated. Now last but very important, we can prevent UTI through hydrating ourselves, fluid intake for more than 2 liters per day, cranberry juice that can maintain the acidity of urine, and avoiding the potentially irritating feminine products. They can cause rashes and then irritation, which can obviously lead to contamination and then UTIs, and urinate before and after having the sexual intercourse. So thank you so much. Please, if you like this video, subscribe and like the button